In this case, we will be focusing on capsulitis. The chief complaint. A 55-year-old female presents with complaint of jaw pain when opening wide or chewing hard foods. She periodically hears a crunchy noise in her right jaw joint. She's been diagnosed with mild rheumatoid arthritis, which affects mostly the joints in her hands when waking in the morning and when the weather is cold. So the history of her present illness. This began about 3 weeks ago. The causation is unknown. The type of pain she's experiencing is an achy, sharp pain. The frequency is usually just when opening wide or chewing hard foods. And this pain lasts for seconds to minutes. The severity is moderate to severe. And really what makes it worse is function, and what makes it better is non-function. This patient's medical history includes rheumatoid arthritis, high cholesterol, anxiety, and history of sinus infections. She does have a penicillin allergy. Her current medications include simvastatin, Xanax, and acetaminophen as needed. She has no history of surgeries. Her family history is diabetes, hypertension, and cancer. Under social history, she does have anxiety. However, she denies any clenching or grinding of her teeth. She has no headache history, and her sleep history is normal. When conducting the extraoral exam, our findings are as follows. The palpation of the craniofacial muscles showed that the right masseter had moderate pain when palpated. She did have some mild tenderness to palpation of the left masseter, right anterior temporalis, left anterior temporalis, and right SCM muscle. When palpating the temporomandibular joint, her right dorsal condyle had moderate to severe pain. She also had some mild pain in the left dorsal condyle, but the right dorsal condyle was of most concern for her. The max pain-free opening for this patient was 40 millimeters, which is the minimum we want to see. Her max opening with pain was 46 millimeters. She's not really restricted, but she does have pain. The right and left lateral max open was 10 plus millimeters, which is normal. And when listening to the TMJ with the stethoscope, there were no joint noises detected. We took a panoramic X-ray in this case, which showed no bony changes in the condyles. They are of normal shape and well corticated. For the diagnosis, I diagnosed capsulitis and localized myalgia. The treatment plan would include, number 1, myofascial protocol, including avoidance therapy, NRES stretch, and thermal therapy for the muscles. Number 2, I recommended nabumetone anti-inflammatory. Number 3, discussed possible future TMJ cone beam CT to assess the bony structure of the joint. We did take a panoramic X-ray. However, a cone beam CT is more accurate in assessing the bony structure of the joint. And number 4, discussed possible future TMJ steroid injection or Hyaluronic injections if the conservative treatment is ineffective. Medications and follow-up. So for this case, I prescribed nabumetone 500 milligrams, 28 tabs, take 1 tab 2 times a day for 2 weeks. For follow-up, we'll reevaluate the symptoms in 2 weeks. Patient is aware of possible future progression of treatment if the conservative treatment is ineffective. So what is capsulitis? So capsulitis is when we have inflammation in the joint causing painful joint without any osseous changes. How is it diagnosed? Well, normally a joint pain is aggravated by function, and if you remember in this case, this is actually when she has pain is on function. We actually look to detect the capsulitis by palpation performed by applying 1 kilogram of pressure to the lateral and dorsal capsule of the TMJ. And the pain should be at least moderate to palpation. The treatment includes avoidance protocol, staying away from those kind of foods that would aggravate the joint, like the hard foods in this case for this patient. No gum chewing, avoidance of habits that may be affecting the joint. NSAIDs, topical or systemic, and also, if severe and other treatments have not worked that are more conservative, we could do intra-articular injections of corticosteroids or hyaluronic acid. When a patient has stomach issues such as GERD, ulcers, etc., and is not able to take systemic NSAIDs, topical NSAIDs are the obvious choice for that patient to start with. But in this case, the patient had no issues with their stomach, so which do we choose, topical or systemic NSAIDs? Well, a meta-analysis was conducted in 2004 by Lin and Company on the efficacy of topical NSAIDs on treatment of osteoarthritis. In their conclusions, the topical NSAIDs were better than placebo in the first 2 weeks of treatment. Topical NSAIDs, however, were inferior to systemic NSAIDs in the first week of treatment and were associated with more local side effects such as rash, itching, and burning at the site. And in weeks 3 and 4, they were no better than placebo. So if we are able to give systemic NSAIDs, that would be the better, more effective treatment for the patient that doesn't have any issues with taking systemic medication.